All right, I will get started then. So this morning, we're going to start off by talking about renal ultrasound or renal POCUS in ED, in particular in relation to renal colic. To give you context on why I've chosen this topic today, is everyone else on mute? Sorry, there's a bit of background noise. So as background, I've been doing quite a lot of ultrasound in the ED lately, and ultrasound of the kidneys is something I've only done a couple of times and found it to be quite useful and interesting. So I wanted to learn a little bit more about it. And as part of this presentation, I seem to have accidentally gone on a little bit of a deep dive on renal colic and our imaging choices. So what we are going to talk about today is renal colic. We're going to just briefly go through a little bit of standard med school style pathology. Then we're going to talk about choice of diagnostic imaging in renal colic, the evidence around it, and how we might use renal ultrasound point of care in ED in obvious renal colic. And then we'll talk about how to actually do point of care ultrasound with kidneys. So I think this is relevant because renal colic is really, really common. It's a very common presentation in ED. 1 in 10 Australians in their lifetime will suffer from renal colic, men much more than women. There's about a 50% recurrence over 5 years. And what we do know is that a large proportions of stones pass spontaneously, which is a fact that's quite relevant for our imaging choices, I think. So our typical clinical features, as we all know very well, we get lots of pain, flank or loin to groin pain, severe acute onset. Patients are unable to find a comfortable position. They all look like they're trying to give birth to their kidney stones. They are nauseous, vomiting, they get hematuria, and generally their examination is very benign in terms of their abdomen. So when we're working up patients with renal colic in ED, the goals as I see them are to, number 1, exclude dangerous differential diagnoses, and 2, identify stones that do need urological intervention versus symptomatic or expectant management. So as we know, our differential diagnoses in renal colic are thusly the one we care most about, or we talk about most, is AAA, particularly in the older male population, but also things that give us flank pain, can be pulmonary problems, other urological problems like pyelonephritis, testicular torsion, gynecological issues, biliary issues, and of course intestinal issues are part of our differentials. When we talk about renal colic, some renal colic is uncomplicated, and then there are some patient presentations that are complicated and do need urological interventions, and those are the infected obstructed stone, which we know is a urological emergency, patients with an acute kidney injury associated with their kidney stone, patients with single kidney or transplant, or those that get really intractable or severe recurrent pain, and those large stones that are not likely to pass spontaneously. Our assessment of our renal colic, of course, always history examination and our and pathology and diagnostic imaging, all fairly straightforward. When we get to diagnostic imaging, really our question needs to be, do we need any? And then what form of diagnostic imaging? I raise this because I think that certainly finding that we are all very prone to a knee-jerk reaction of a CT-KUB for almost everyone arriving in our department with renal colic. It's a very easy test to order, but and I think certainly in a department like ours where we have ready access to a CT, without having to negotiate with a radiology reg, it becomes very, very easy to order that test without thinking about whether or not we really need it or what alternatives there are. So just to talk about kidney stones and how easily they pass, the rate of spontaneous passage, as we know, overall is really high, so 75 to 90%, particularly in those stones that are less than 5 millimeters. But also we know the ones that are closer to the bladder are much likely to pass spontaneously. So up to 84% of lower ureteric stones, those ones that are below the SI joint, usually at the VUJ, will pass spontaneously. And I think I didn't necessarily always appreciate the difference between these upper tract stones versus lower tract stones. This is some data from a study that was performed in 2018, and the authors looked at around 400 patients with renal colic who had CT-KUBs and followed them up at 4 and 20 weeks, and found that stones, obviously we can see here, upper tract stones, above 5 millimeters, there's only sort of a 20-30% chance these are really going to pass. Whereas stones that are sitting down low in the VUJ at 5 millimeters, there's really 75-80% chance they're going to pass spontaneously at the 4-week mark. So we've got a little bit more leeway in terms of expectant management for those lower stones. So our imaging choices in renal colic, I think we need to keep in mind our goals of our assessment of these patients. Does the patient actually need imaging? And complicated renal colic, or where you've got a significant concern for an alternate differential, I think our clinical assessment is usually pretty good at directing us as to what sort of imaging we need. Whereas when it comes to uncomplicated renal colic, where we don't have any of these complicating factors or concerning differentials, we need to think about our imaging choices. So imaging choices: no imaging, ultrasound of the renal tract, either POCUS, formal, or both. CT-KUB, previously X-ray KUB or intravenous pyelogram were part of the workup. These are really no longer happening anymore. There's no good reason to do either of those. So CT-KUB is the gold standard, highly sensitive and specific for stones, but we need to recognise that there's radiation risks. Standard KUB is 10 to 12 millisieverts. There is a low dose protocol, which is reportedly somewhere between 3 and 5 millisieverts. But it's still a significant amount of radiation, given we know that chest X-ray sits at about 0.1. So in the US, there is evidence that more than 90% of patients diagnosed with kidney stones end up with CT-KUB. However, over the last couple of decades, where CTs have become much more common, there's been very little change in admission or intervention rates. So we need to question why we're doing all of these CTs. And we know that patients who have renal colic, it does become a chronic condition. They get multiple stones over their lifetime, multiple CTs, maybe up to 10, maybe up to 20, and we need to keep that in mind with our imaging choices. So how can we use renal ultrasound in ED to reduce radiation exposure, is that question. Ultrasound has no radiation, fast, can be performed at the bedside. It's actually more available than CT in some centres, probably not in a centre like ours. It's not as sensitive or specific as CT at detecting stones, but it's quite good at detecting hydronephrosis as a sign of obstruction. But we know it's probably challenging in patients with larger body habitus. So when thinking about imaging choice, I started with looking at what our guidelines are. And I know that a lot of people feel like medical guidelines are for people with simple minds, but I'm a simple person. I'll take that. ASIM guideline for imaging choice, it was last updated in 2012. It includes a combination of X-rays, CT pyelograms, all kinds of weird and wonderful things, and I'm not sure that it's entirely up to date. Up to date talks about imaging choices in renal colic as CT being pretty much the first choice for every patient unless the patient's pregnant. Whereas the imaging guidelines that are used in Australia, Safer Care Victoria, the New South Wales Emergency Care Institute and RACGP guidelines use the Western Australian Diagnostic Imaging Pathway, which recommend ultrasound for most cases of typical or uncomplicated renal colic, even in patients who are presenting for the first time over 50, and consider no imaging at all in patients with recurrent presentations. So this is their guideline, as you can see, ultrasound of the urinary tract. So how can we use ultrasound in ED? So I'd like to just get a little bit of a hands up. What's our practice in ED? What do people usually do when a patient presents with fairly typical renal colic? They're in a lot of pain. They haven't necessarily got all of the right analgesia yet. Are people ordering ultrasounds in their practice or going straight for CT?
Elise, once upon a
Yes.
time when I had time and didn't have to supervise anyone, I would have done a bedside ultrasound because I've got a CCPU in it. But
absolutely,
been about 4 years since I did that, and that's coincided with having to supervise and do a lot of other things. So now I'm just ordering CT KUBs left and right.
Absolutely. And I think that's been my practice as well, Ollie. I think that, you know, in the past, what I might have done would be give them adequate analgesia, get their bloods off, give them antiemetics, watch them, and then decide whether I need a CT if the patient's pain is not settling down. But now, if you do that, you finally get to see the patient, you finally order some analgesia. They might get that half an hour later. You might not get back to review them for another hour, 2 hours to see if that analgesia has actually worked, and then ordering a CT. You know, a department like ours that's so busy where flow is so important, I think I'm the same. You order the CT straight away just to get the diagnosis right, get the patient moving. And so I think that's a really, really common practice. I had a quick look at the evidence for imaging in renal colic to sort of set the scene of how we might be able to use bedside ultrasound. So there was a really big trial done in September 2014, which got a lot of excitement around it. It was a really large prospective CT. There was about 3,000 patients. And they compared the outcomes of patients who had an ultrasound for renal colic versus a CT. And they found that the risk of having a high risk diagnosis or a complication in the first 30 days after that presentation was low overall and didn't really differ between the two groups. On further analysis, there's quite a lot of flaws to this trial, and there wasn't a lot of decisions that could have been made about it. There was another study done in 2017 looking at the accuracy of ultrasound for renal stone detection and size, and questioning, is it good enough to help us make management decisions? So it was a retrospective review of 486 patients, all with confirmed kidney stones, and all of these patients had had both an ultrasound and a CT. And they found that overall ultrasound had pretty low sensitivity for detecting the stones compared to CT, and they concluded that overall ultrasound was not good enough for making management decisions in renal colic. But the authors of this paper, number one, were urologists, not ED people. And number two, the population that they looked at were not exclusively ED patients. In fact, a huge proportion were not. So there were outpatients, there were people coming for follow-up, and the indications for the imaging itself wasn't even necessarily always simple renal colic. So we don't take much stake in that. This study was really interesting. It's from June 2018, a systematic review and meta-analysis of the accuracy and prognostic value of ED POCUS for detecting nephrolithiasis. And they looked at 9 studies looking at the accuracy of ED POCUS in the diagnosis of stones, and found that overall the sensitivity was about 70% and specificity was 75.4%. So not rip-roaring, but if moderate or severe hydronephrosis was detected, the specificity increased to 94%. They also looked at the relationship between the degree of hydronephrosis and the stone size. And they found that increasing hydronephrosis was associated with increasing size of stone, but it was a reasonably small data set. They also found that one study that demonstrated that if hydronephrosis was detected on a bedside ultrasound, there was reduced risk of an important alternative diagnosis, which I think is important. Then in 2019, there was a systematic review performed by a 9-member panel, including 3 ED physicians, 3 radiologists and 3 urologists, looking at choice of imaging in simple renal colic. They reviewed all of the literature available on the topic, and they provided an evidence-based consensus and provided imaging recommendations, excuse me, on 29 common patient vignettes. And the choices that they were reading each of these vignettes, they were each able to choose either no imaging, point of care ultrasound, radiology performed ultrasound, reduced dose CT, or a standard abdominal CT. So I thought it might be interesting to get a little bit of involvement from everyone and go through some of these patient vignettes. I'm not going to go through all 29 because you'll all die of boredom, but just to see what you guys think, how this relates to your practice, and what we think. All right, so 35-year-old man who's had 2 prior kidney stones. They both passed spontaneously. He's got acute onset flank pain in the last 3 hours. He's got nausea and vomiting and has hematuria on his urine dip. No abdominal tenderness, and his pain is getting better with some analgesics. What kind of imaging would you guys choose? Anyone can shout out.
I
mean, you know what?
Ultrasound on him just because he's young. That's my only sort of reason, I guess.
Yeah. And Abra, is bedside kidney ultrasound part of your practice at all?
No, unfortunately, I'm not. I can do it, but I'm not credentialed in it, so it's not really part of my practice. So, but I would just request a non-urgent formal ultrasound for him at some stage.
Yeah, great. So this consensus group recommended either a half-half. They were split on either no imaging at all or a bedside ultrasound. No one this panel suggested a formal ultrasound or a CT.
And just reading the comments as well, I think Seema said no imaging, which is great. And yeah, David said bedside DD-POCA. So yeah, I think that's good. Yeah,
great. Thanks, Abra. If you can keep an eye on the chat, that would be fantastic, and pipe in. So now this man, same guy, he has had an ultrasound. There is hydronephrosis on the side that he's had the pain, no stone visualized. Would that change anything? Would you do anything differently, choose any other imaging at this point?
So my answer would be no. I wouldn't change anything.
Yeah.
And I'm assuming the others would also say the same thing in the chat, given his pain is resolved.
Yep, agreed. So they said universally, the panel said no further imaging. You've got the diagnosis, the pain's getting better, symptomatic management. All right, so same guy, done a bedside ultrasound. Now there's no hydronephrosis, no stone visualized. His pain's still better. Would anyone do any more imaging or leave it? Abra, what are you going to do?
Like no imaging really if there's no hydronephrosis. Well, the thing is, I guess the question here is if it doesn't show any hydronephrosis, but you've got a pretty good clinical indication that with hematuria, it's possibly a renal colic. I don't think I would do anything different. I would just leave it be.
Yeah, I agree with that. I think if his pain's better, then it's most likely he's got renal colic and his pain's getting better. We can manage him expectantly.
Just reading in the chat, I think Emma mentioned probably if everything is okay, nothing, but she also recommended bloods, which I think is reasonable.
Yeah.
Seema has sort of discussed educating the patient and still no imaging. And Ollie mentioned the shared decision-making sort of thing with the patient as well.
Yeah, agree, absolutely. So yeah, it is, an uncomplicated presentation. They haven't mentioned bloods, but presuming this young healthy person has normal renal function and no signs of infection, then yeah, I agree. Treat them symptomatically and red flag and follow up as an outpatient. So what if same patient, but it's his first presentation? Would that change anything? I won't torture everyone for too long. They recommended for this patient, universally recommended, that we do a bedside ultrasound looking for hydronephrosis. But interestingly, and same as in the last guy, they recommended POCUS as bedside ultrasound, but regardless of whether there was hydronephrosis, they recommended no further imaging. So it's interesting that we're curious, and clearly this panel of experts is curious to know whether or not we've got evidence that there is hydronephrosis or signs of a kidney stone, and yet, irrespective of the findings, probably wouldn't change anything. All right, so now this guy is 55, but he has had 2 prior kidney stones. Pain's getting better, no abdominal tenderness. Image or not image? So interestingly, this panel said, again, either no imaging or POCUS, even though he's an older person, that at this stage, if it's classical for renal colic, he's had previous scans, they would do either a bedside ultrasound or no imaging at all. Even if he had no previous history of kidney stones, so if he's got this is his first presentation, he's 55 years old, pain's getting better, at that stage, I think we would probably all then choose a CT KUB for this guy. Do you agree?
Yeah, I would.
Yeah, me too. Me too. Okay, so now we've got back to our 35-year-old man. He's got pain for 3 hours, no prior history of kidney stones, nausea, vomiting. He's got some hematuria, benign abdominal exam, but his pain is not relieved. He's still got ongoing pain. I think at this stage I would be doing imaging, ultrasound or CT. CT for this guy. His pain's not relieved even with intravenous analgesics. We'd be concerned that we're not that the size of the stone, so we want to find out. All right, I might skip through some of these. 35-year-old woman, first episode. We're probably going to do an ultrasound, a POCUS or a formal ultrasound on this person. I think they're more likely to do imaging in a woman rather than a man with likely kidney stones, because obviously we've got more things on our differential list than we would in a man. Pregnant women, everyone said ultrasound. I think that's a bit of a no-brainer, to be honest. If there's hydronephrosis, they've said no further imaging, got your diagnosis, you're done. I found this quite useful. 35-year-old man who had lithotripsy with no stent 2 days ago, comes back with pain, and pain's getting better. All of them said either an ultrasound or a CT for this guy, mostly because they want to look for a hematoma. For a man who has had a stent put in yesterday and represents with pain, I think most of us would put a knee jerk to a CT KUB. They said, including neurologists, everyone said a bedside ultrasound would be sufficient to assess stent patency. If there was hydronephrosis there, it would suggest a non-functioning stent, and that would warrant further review and urology referral. So my takeaway from this was that POCUS does have a role in ED for renal colic. The diagnostic accuracy is okay. It's not great, but it's definitely recommended where we've got uncomplicated renal colic, even when it's the first presentation. It gives us the opportunity to confirm the diagnosis and adds to our overall assessment. But we may not change management in response to our findings, but it just adds that little bit of extra evidence to our clinical assessment. Now, I'm sorry if I start getting a little bit incoherent. As some of you know, I finished my night shift this morning, and so I'm going to start getting tired soon. So, renal point of care ultrasound. So how do we do it if we are going to do it? I'm just going to talk you through doing that. And I think it's actually, reasonably straightforward. So we're going to put the patient in a supine position. We're going to elevate their arm to increase the rib spaces. You can sit the patient up or put them in a lateral decubitus position if needed to get more access to the kidney. And the views we're essentially getting right upper quadrant, left upper quadrant, and pelvis. So these are views that we're all very familiar with in doing our FAST scans. What's different about this is that we're training our eye on different parts of the anatomy in these views. So probe choice, we're going to use a curvilinear probe on an abdominal preset, but you can also use a cardiac probe on an abdominal preset if it helps you get between the ribs better. So let's go over the renal anatomy, because I'm sure that we all think about this on a regular basis since med school. Kidney is made up of the cortex and the medulla. We've got this nice cortex around here. These are the renal pyramids. And on ultrasound, these renal pyramids appear as hypoechoic triangles or areas around the renal pelvis and the calyces. And the renal pelvis and calyces sit around here, and they appear hyperechoic in a patient that doesn't have hydronephrosis. So the ultrasound features that we're looking for when we're looking for kidney stones, we're looking for hydronephrosis. We're also looking to see if we can directly visualize the stone. Now, that's uncommon. We might be able to see a stone if it's at the PUJ or the VUJ, but anywhere else in the ureter, we're probably unlikely to see it, but it is possible to look for it. The third thing we're looking for is absence of ureteric jets in the bladder. That's urine squirting into the bladder. And we're looking for this thing called twinkling artifact, which looks really wonderful, and I'll show you at the end. So when we're looking at the kidneys, the images that we're looking for, we're going to try and get a longitudinal and a transverse view through each of the kidneys. Normal adult kidney is about 10 to 11 centimeters long. Hydronephrosis. So when we look for hydronephrosis, we're looking for a hypoechoic fluid-filled area in the middle of the kidney, and it's graded, grade 1, 2, 3, and 4. That's difficult for me to remember. Mild, moderate, severe is much easier to remember. Mild, we start with dilatation of the renal pelvis. When we get to moderate, we start getting dilatation through to the calyces as well, which starts to be these little finger-like projections. When we get to severe hydronephrosis, that dilatation, that hypoechoic area becomes contiguous with the medullary pyramids, which are usually hypoechoic, and we get the appearance of thinning of the renal cortex. So I'm just going to run you through a quick, sorry, give me one moment. Can you see that I've changed my screen here? Or no?
It's just showing the link,
Sorry.
coreultrasound.com.
Hold on, let me just fix this. Okay. Can you see this video?
Not showing up on the screen at the moment.
Nope.
Do you want to, I think you might be sharing your PowerPoint, so maybe
I know, I'm trying to just, hold on.
maybe you can stop sharing and then just share screen instead. Maybe that might, oh, there you go. We can see it now.
You can see it now? Fantastic. Yeah. Excellent. All right. So this just goes through hydronephrosis really nicely. All right.
We just haven't got any audio, Elise.
Oh, you don't?
But we've got, I think you have to,
okay,
these ones, either talk over them or share the system audio, I reckon.
No worries. I'm going to talk over it. All right. So this is the kidney. We've got the pyramids here, these hypoechoic areas. And this is the kidney in longitudinal. And this is the renal pelvis in the middle. And as you can see, it's hyperechoic. Here we've got some dilatation of the renal pelvis here going into the calyces, and this might be termed mild hydronephrosis. You can see in this video, we're starting to get slightly more severe, some moderate, where we're getting into those calyces there with our dilatation. And again, we're starting to get into the major calyces and minor calyces through here. It's fairly significant hydronephrosis. This video is reasonably getting through to more severe hydronephrosis, where it appears that we are contiguous with those pyramids. Here everything's looking quite dilated. So as you can see, it's reasonably obvious when there is moderate to severe hydronephrosis. I think we would all, without much training, pick up the presence of hydronephrosis quite well. And this is a really thinned one. We've got quite severe hydronephrosis there. So you've got normal, mild, moderate, and severe. Okay. Let me just go back to my screen now. Okay, can you see my PowerPoint again now?
Yeah, we can, yeah.
Great, excellent. So what are some mimics of hydronephrosis? As I said, the medullary pyramids are hypoechoic spaces, quite normal. Hydronephrosis will start at the renal pelvis and move outwards towards the cortex. So if you can see these hypoechoic areas, but the pelvis still looks normal, then this is not going to be hydronephrosis. Renal cysts are, again, a discrete anechoic structure that aren't associated with the dilatation of the renal pelvis or the calyces and don't seem to have any connection with the collecting system. And if you see a sort of discrete hypoechoic areas, is why it's important to look in multiple views, in longitudinal as well as in transverse, to try and identify whether that's got any connection with the collecting system. But renal vascular malformations can also appear as hypoechoic areas, and you can use your colour Doppler to discriminate that from the collecting system. So just going back to just quickly causes of hydronephrosis, obviously ureteric calculi is what we're looking for when it's usually the clinical context that we're going to be looking at kidneys for and looking for hydronephrosis. But keeping in mind that there are other things that can cause it too. Any kind of malignancy within the abdomen that's causing obstruction of the ureter, either unilaterally or bilaterally, can cause hydronephrosis. There can be chronic bilateral hydronephrosis from either prostatic hypertrophy, neurogenic bladder, or malignancy. So if the patient's got unilateral pain, always worth looking at the other kidney just to establish whether or not this is unilateral pathology or bilateral. So kidney stones, can you see them? It's possible. So if they're in the renal pelvis, the PUJ or the VUJ, you might be able to see them. They're going to appear as hyperechoic areas with posterior acoustic shadowing, and you're less likely to see them elsewhere in the ureter. So that's really because of bowel gas. But it is possible to see them in some cases. And this is a cool video I'll show you of a mid-ureteric stone sitting here. Stones, as we know, can get stuck at the pelvic rim as the ureter crosses the iliac vessels. And one way of looking for them is to identify the iliac vessels and slide the probe along the iliac vessels from origin to groin, looking for a hypoechoic tubular structure, being the dilated ureter running obliquely over those vessels. And this is an image pulled off the internet nicely. I only wish I can create an image like this one day. But as you can see, you've got the kidney stone here. You've got this dilated ureter running across the iliac vessels here. The next thing we can look for in the bladder is the ureteric jets. Urine flows from the ureter into the bladder at fairly regular intervals. It can be as quite frequently, but it can take a couple of minutes for each ureter to produce urine. You can use colour Doppler to detect the unilateral absence of a ureteric jet, which would suggest ureteric obstruction. And we do that by looking at the bladder in the transverse view. You decrease the colour Doppler scale to 10 to 20 centimetres a second and sit nice and still and watch. And so a ureteric jet looks like this little red flash here coming out from this right side on this patient. And you would watch to see if you're getting a jet on the other side as well. And if after a couple of minutes you're only getting jets on one side, that's a suggestion that there's possibly an obstruction on the other side. So twinkling artifact, this looks really fun, little rainbow flashy thing. So this is an artifact that can be seen near the bladder where a stone is present, and it's using colour flow Doppler, gives a focus of alternating colours. It gives this appearance of turbulent flow, and it's related to, I understand, the scatter off the really jagged edges of a ureteric stone. And if you do see this twinkling artifact, apparently it's highly predictive of the presence of a stone, and it's much more sensitive for small stones than acoustic shadowing is. So looking for that particularly around bladder as well. So thinking back to now, how might we use bedside ultrasound to look at our kidneys? The patient populations where I think it might be really useful are obviously pregnancy and flank pain. Obviously, we don't want to irradiate these women. They're probably a patient group that you might get a formal ultrasound in anyway, but doing a bedside ultrasound might just give you that little bit of addition to your clinical assessment. Patients who are young, healthy, and present with flank pain, and you feel that this is most likely clinically consistent with uncomplicated renal colic. If you can get the pain under control of these patients, they probably shouldn't all have a CT KUB initially, even with reduced dose scans. There is a reasonable radiation load with these patients. So using a bedside ultrasound might give you the opportunity to confirm your suspicions if there's the unilateral hydronephrosis, and have a discussion with the patient about that diagnosis, their expectations, and reasons that they might need to come back for more formal imaging or for CT imaging. The other population group that it might be useful for is that older patient with flank pain where there is a much wider differential. When they're start out undifferentiated and you think you're definitely imaging this person, but am I doing a CT KUB? Am I doing an abdominal aortic angiogram? Obviously, we'll use our AAA scans to look for an angiogram, but if at the same time we're doing that, if we're able to look at the kidneys and see a unilateral hydronephrosis, that's really helpful for us. It might give us the opportunity to say, okay, we can just do a CT KUB. We don't need to do the full abdomen, or if we see nothing, we might go ahead and do a different scan. So it might just help us direct our imaging choices. So take home, renal colic's really common. We probably are doing too many CTs, and for the reasons that Ollie was discussing earlier, it's easy, it's quick, it gives us a firm diagnosis, it gives us all the information that the urologists want to know. But it is possible that we're giving a little bit too much radiation to particularly our younger patients. We know that the vast majority of kidney stones pass without need for urological intervention. So having the exact detail of where the stone is, exactly how many millimeters it is, might not necessarily be necessary. So POCUS can help us confirm our clinical diagnosis, help us aid in counselling our patients. If a higher degree of hydronephrosis is suggestive of a larger stone, though, which we don't really have fantastic evidence that that's the case, do we then need to do a CT to guide our further decision making? That's a question that I think we need to ask ourselves. And I think if we all saw a really quite severe hydronephrosis with cortical thinning, I think most of us would be thinking about then doing a CT to interrogate that further. And obviously remembering CT is always indicated if there are clinical features of complicated renal colic or the diagnosis is unclear. Does anyone have any thoughts, comments, things they'd like to talk about with bedside kidney ultrasound or our management of renal colic?
No, thanks, Elisa. I guess what I wanted to sort of say was it shows you, I think, with the modality, as long as you understand what the pitfalls are of using it, when to use it in the patients, and when you need to know to pull the trigger to do some more advanced imaging. I think that's the key. But it also shows that I think sometimes you have to pull back on some of your sort of decision making and choices, and you have to keep reevaluating them over time. I think a lot of us, like you said, we do probably order too many CTs. I think might just, like, after this presentation, so think about, maybe think a bit more on some of these patients, and maybe be a bit more sort of careful in our choices, and sometimes you have to accept that, if it doesn't work, it's okay to delay slightly the care of the patient in some ways, to say, well, I'm trying something that's a bit more less risk to them, and then if that doesn't work, I'm quite happy to then bite the bullet and take that next step. And you just have to choose the right patients to do that. And I think it's a case by case, I guess, a proposition, isn't it?
Yeah, absolutely. And I think there are sort of certain groups where this might be more useful than others. As you say, the first presentation of an older person, you're almost certainly going to do a CT. But maybe these younger patients where the clinical diagnosis, you're pretty sure, this might just give you that little bit of extra confidence in your diagnosis without subjecting them to a CT.
Excellent. Thanks, Elise, for doing that. I'll stop the recording for this part of the session now, and I think the next little bit you're talking about is a journal club, isn't it?
Yeah, that's right.